Okay, thanks for Dr. Ahmed Elazab, ENT specialist, for sparing some of his time to present such an interesting subject, epistaxis, which is one of the most common presentations in primary and secondary cares. Please go ahead, Dr. Ahmed.
Okay, Assalamu alaikum. I am Dr. Ahmed Elazab, ENT specialist doctor at Prince Alexander Hospital in Harlow. I'm going to present today epistaxis, and the first objective of us is to know that the main aim in treating epistaxis is to control it. The epistaxis, the goal is to control. First of all, we will have some anatomical background. The nasal mucosa is highly and very rich in blood supply. The blood supply comes from the anterior, the external carotid and internal carotid arteries. Internal carotid arteries supply the nasal mucosa through the anterior sigmoidal artery and the posterior sigmoidal artery, while the external carotid artery supplying the nasal mucosa through the sphenopalatine artery, which comes from the maxillary artery, and the greater palatine artery as well comes from the maxillary artery, and the superficial artery coming from the facial artery. All of these are coming from the external carotid artery. Okay, they have here like anastomosis here of all these branches making the Kesselbach plexus, which is in the both sides of the anterior inferior part of the nasal septum, area called Little's area, which is the most common cause of most common site of anterior epistaxis. Causes of epistaxis. There is multiple ways to classify the causes for epistaxis. To simplify it, I just put it in enumeration. Most common causes of epistaxis idiopathic, maybe due to nasal dryness or even without any cause. 80% of cases we don't find any underlying cause for causing this nosebleeds. The other cause is trauma, which can be nasal picking, digital picking the nose, or external trauma to the nose, or iatrogenic trauma after any nasal surgeries. Other cause including coagulopathy, including idiopathic thrombocytopenic purpura, disseminated intravascular coagulopathy, and any other causes of coagulopathy can affect the nasal mucosa. Drugs like warfarin, aspirin, clopidogrel, apixaban, dabigatran, rivaroxaban, all these are very common in patients suffering from epistaxis, especially in old age. Other causes like chronic granulomatous diseases, like sarcoidosis, granulomatous with polyangiitis. There is other rare causes, including neoplastic causes and hereditary causes. The most common thing in the most common neoplastic cause is angiofibroma and inverted papilloma and squamous cell carcinoma. Hereditary, like hemophilia, von Willebrand disease, are also common in children. The management of epistaxis includes three main lines of management. First of all, we assess the patient and do resuscitation and take a very quick history. Then either we choose to do direct therapy or indirect therapy. It depends upon the patient's condition. So assessment includes airway, breathing, circulation, ABC, as any patient for in resuscitation. As long as the patient is stable, patient should be sitting up and leaning forward to prevent any blood clots from falling backwards and making any airway complications, also to know the amount of blood which comes out. You know, there is a severe bleeding or just minimal bleeding. So this is the best way, the best setting of the patient, which is a stable patient to set to know the amount of bleeding and guard against any complications caused by any blood clots. While the patient is sitting, we can assess his blood pressure or insert cannulas, have intravenous access to have blood for investigations, and take a very targeted history to identify the cause behind this type of bleeding. Either it is primary cause or secondary cause, and start your appropriate therapy. So if it is something local inside the nose, like trauma or any local cause inside the nose, you will use that direct therapy. I will come again to the causes. As I said, there may be some dryness in the nose, like this case. You will see the dryness cause some blood vessels to be prominent blood vessels, cracked blood vessels cause bleeding. So this is a local cause. You can directly identify this cause and try start to treat it with a direct therapy. Direct therapy includes nasal cautery, either by silver nitrate or electrocautery. So silver nitrate, how it works, if we have a direct cause of nosebleeds and we identify the site of nosebleeds, which is most commonly in the anterior part of the nasal septum, as we said, the lateral area. So we will numb the nose with local decongestant analgesic, and then do some suctions, clarify the area of bleeding. Then we will choose to use the silver nitrate, which is more common. Silver nitrate is a chemical material. When it applied to a wet area, the silver nitrate itself liberates with the head of the water, liberates nitrogen oxide, which is causing chemical cautery of the blood vessels and initiates fibrosis in the blood vessels. So this helps to control the bleeding, point. This one of the common causes also of local causes, which is septal perforation. You can see here, so this is the nasal cavity, and this area should be the nasal septum. And you can see the other side of the nose, so this perforation, septal perforation. Always the bleeding comes from the edges of the perforation, and this is considered a local cause. So we directly identify it and we can treat it directly. Once we did this and the bleeding stopped, we should do a further examination of the nose, including nasal rigid endoscopy, to identify any other causes. The patient may have another cause in the nose, there may be another bleeder elsewhere. So yeah, typically we should do this following controlling the bleeding. This is the instruments that help us to control the bleeding. We should have a good light source to do targeted examination inside all the areas of the nose. This is the Sodicam nasal examination, using nasal examination to dilate the nasal speculum, the nearest to see inside the nose. Okay, and this is the nasal vasoconstrictor agent, either metazolamine or adrenaline, diluted adrenaline. And this is the silver nitrate sticks. This is the rigid endoscopy, and these are settings that you should arrange before attempting to do the direct therapy. This is a section tip, and these are the tubes to have the essential blood investigations If you do examination of the nose and you cannot find a specific site of bleeding inside the nose, and the patient's history suggested that the patient may have a secondary cause of nosebleeds, like patients taking anticoagulants, or patient with blood disease like leukemia, or a patient with a tumor inside the nose, or anything that you know that it is difficult to control with the direct therapy. So we shift to the indirect therapy, and it is even there is a specific point of bleeding, and you choose to do the indirect therapy, it is very acceptable, because as long as you don't have the essential instruments to do the direct therapy, you can easily use the indirect therapy, as it is also achieving the goal of the treatment, which is controlling the bleeding. So the indirect therapy is typically a nasal backing or a topical hemostatic compound. A nasal backing including anterior nasal backing and posterior nasal backing. Anterior backs like nasal tampon. This is what we call Murocel. It is rigid while it is dry, rigid material, so you can introduce it inside the nose. And once it is mixed with saline, it will transform into spongy material. As you can see here, it is the form while it is dry, and this is the form when it is mixed with saline. It transforms into very spongy, very soft material. We always find our colleagues introducing the nasal tampon in this way, in direction upwards, while the nasal mucosa and the nasal airway is horizontal. So this is the correct way to insert the nasal tampon. Should be in a horizontal way to not to injure the inside structures, and also to achieve a good insertion of the nasal tampon. There are other types, implantable bags, including the most common one of them is the rabbit rhino. These are two types. The first one is anterior rabbit rhino and anteroposterior rabbit rhino. The difference between them is that the anterior rabbit rhino contains only one balloon. When it is inflated, it only controls mainly any site of bleeding anterior in the nose. If we can go back to the, if the site is here, anterior anyway here, so the balloon will fill this area and control any site here. This is the anterior balloon. If it is an anterior posterior balloon, so there will be two balloons, one balloon to cover this area and another balloon to cover this area as well. So this is the difference between them. So if you're going to use the nasal balloon, I will suggest to use the anterior balloon only first, and see if it is successfully controls the bleeding or not. If it is not successful, it is easy to remove and put anterior posterior balloon. If you suspect that the bleeding is not is the posterior bleeding. Okay. How we use these ones? We should introduce both. They should be put in a warm saline before insertion in the nose. Once they mix it with warm saline, they become soft and easily introduced inside the nose. Before introducing any of these nasal backing, you should do a proper nasal section, because most of the times patients come with a well-formed blood clot inside the nose. This blood clot may be dislodged and drop through the postnasal space and drop into the airway and endanger the airway. Also, the blood clot itself sequesters platelets and makes bleeding also affecting the hemostasis by sequestering all the platelets. So removing the blood clots is one of the important steps in controlling the bleeding. There is other types of nasal bleeding using the urine catheter, but it is very old. I think it is not used today. It is completely replaced with the ribodrymal anterior balloons. If the patient is still bleeding and you suspect that the bleeding cannot be controlled with the anterior backing on either on one side or even you can see both anterior backing on both sides. If the patient is still bleeding and there is no way to take him to the theater, there is other ways you can use the topical hemostatic compounds, including tranexamic acid and Flucil. Flucil is one of the options available. It is expensive, but it's less expensive than taking the patient to the theater. It is the solvable material. It will fill all fill all the nasal cavity anteriorly and posteriorly once mixed with blood, and it is very effective way to control nosebleeds. There is also the solvable material named Nasopore. You can see, I'm sorry, it is white shades. I'm sorry, it is not very clear. It is one of the solvable materials. Once it is introduced inside the nose, it's very, very soft. Once introduced inside the nose, it transforms into gelatinous material. Within days or 1 or 2 weeks, it will be completely disappeared from the nose. Patient will notice some gelatinous blood clots coming out from the nose. It is actually the nasopore, not an active bleeding over the 2-3 days after introducing this nasal tampons. This is the instruments that you need to prepare before attempting to put the nasal tampons. Patient should have a bowl to have maybe vomiting in this bowl. You should have a suction catheter, a nasal catheter, plastic cups to ask the patient to do gargling to make sure that there is no active postnasal bleeding. Examination, I mean, to examine the throat once you put the bag to make sure that there is no blood is coming through from the nasopharynx to the oropharynx. This is the syringes to mix any of the tampons with saline. This is the nasal sedicams like nasal speculum. This is the ribodrymal tongue depressor. Okay, and these are the instruments that you should prepare before attempting to do the indirect nasal backing. If these ways are ineffective and the patient still bleeds, it is actually not always the controlling the bleeding, but most of the cases will be controlled with these ways. Once we introduce the nasal backing, we should keep it for about 24 hours to 48 hours to give a chance for healing if there's any local cause. Okay, if the patient is still bleeding and these ways are not effective, so we expect this is a refractory epistaxis and patient should be treated further by other means. These include the surgical intervention or embolization. Surgical interventions include either to take the patient to the theater to do endoscopic sphenopalatine artery ligation. So as we said here in the first slide, so this This is a sphenopalatine artery, which is a main artery supplying the nasal mucosa. So when we ligate this artery, most probably in 90% of the cases, the bleeding will stop. So we access this artery endoscopically through the nose, elevate the mucosal flap, identify the artery and its branches, do clipping this artery inside the nose, and that's it. Most of the cases will be controlled, and it is very effective and less invasive than other options. In some other cases, there may be the main cause, most probably traumatic causes of epistaxis. This cause of epistaxis most probably comes from the anterior sigmoid artery. When this patient cannot be controlled conservatively, and the patient still bleeds after doing the indirect therapy. So we may also do endoscopic or external approach in anterior sigmoid artery ligation. Even though some patients very rarely still bleed after these interventions, so we may do maxillary artery endoscopically or through a cold wall lock approach, or even external carotid artery ligation to control the bleeding. But these are very rare. The other option is embolization. This interventional radiology may do this, but it also carries a risk of maybe ischemia, and it is not safe to be used. It is last choice actually in these days. Here is like a pathway of patients to treat patients with epistaxis. If we have a patient that is more than 18 years old and has no history of trauma, we can use this pathway. First of all, we will assess this patient regarding airway, breathing, and circulation, and see if he is hemodynamically stable or unstable. If he is hemodynamically stable, so the patient should be sit down, as we said, sit down and lean forward, bend the nose for 10 minutes, and after that, either the bleeding stopped or you can do direct therapy using sectioning the blood clots, and put some nasal decongestants, and do the direct therapy. Or the patient is hemodynamically unstable. If he is hemodynamically stable, so we should directly address this first with yes, do everything to control to make him hemodynamically stable first by putting cannula, taking blood for group and save, doing the urea, electrolytes, and blood investigations until the patient is hemodynamically stable. Then we can then look in his nose and stop the bleeding. Yes, if the bleeding stopped by these measures, direct measures, so that's it, and patient can be sent home. If the patient is still bleeding after direct therapy, so the patient we can use the indirect therapy and put nasal tampons or hemodynamic hemostatic agents like Flucil. If the bleeding stopped, the patient should be admitted when he have any nasal tampons or any nasal backing, should be admitted for 1 or 2 days. If the bleeding stopped, we can remove the back and send patient home. If the bleeding didn't stop, so we will take the patient to the theater to do surgical interventions, most commonly sphenopalatine artery ligation. If there is other causes underlying causes like patients taking anticoagulants or patients with coagulopathy or in blood disease. So yeah, we control locally the bleeding with nasal tampons or indirect therapy, and try to correct the underlying cause either by we typically stop the anticoagulant for 1 or 2 days until we can control the bleeding. Then the patient can return back to use it with consultation of the medical team. We incorporate them, incorporate also hematology team in our management of such patients. So this is the key learning point that I was aiming to introduce to you today. So the epistaxis is one of the common ENT emergencies that can be challenging to treat. Primary idiopathic epistaxis is either managed with direct therapy to control the bleeding point. In refractory case, surgery or embolization may be required to control the bleeding. Endoscopic ligation of the sympathetic artery is successful in more than 90% of cases of posterior epistaxis, with a very low complication rate. Management of the secondary epistaxis require treatment of the underlying cause and avoiding instrumentation of the nose as much as possible, and this may cause a problem to exacerbate. Yes, and now I finished. If you have any questions, I will be happy to answer.
Thanks, Dr. Ahmed, for the nice run through the emergency epistaxis control. I do have a couple of questions, but let's start with the floor first. Dr. Mohsen, have you any questions?
Yeah, thank you, Dr. Ahmed, for the presentation. Thanks, Ehab. In ICU, we usually have epistaxis most commonly secondary to nasogastric tube insertion. I just want to ask, from an ENT expertise, is there any specific maneuvers or anything to keep in mind while inserting an NG to reduce the risk of having a bleed after that?
Yes, so NG tube, I don't know if you have the instruments to examine the nose. You have like Sedicam, any type of light source to know first if the patient have deviated nasal septum. So you choose which nostril you can introduce the NG tube through. So if you have these instruments, which is very simple, I think you can have it. Just dilate the nostril and have a look if there is a good airway inside in front of you. So you can introduce the NG tube. I will suggest you always be in the midline. So depend on the patient is, if the patient is awake, you can numb his nose with nasal decongestant analgesic. Okay, then introduce the NG tube through the floor of the nose and to the midline, so you will touch the nasal septum, and this will take you directly to the postnasal space. Okay, if you didn't do this and do it blindly, the patient may have deviated nasal septum, and you make trauma while trying to introduce it. Or you may introduce it and go to the inferior meatus or middle meatus and cause trauma, and patient will eventually bleed, especially if your patient's ICU having anticoagulants and having other comorbidities that will make him prone to this. Yeah.
Thanks, Dr.
Thanks.
So my question, we usually advise people in primary care when they present with epistaxis is try to control it at home by pinching, sitting up, and the other measures you've kindly described. So how much is too much? So I mean, after how often
Yes.
Do we have bleeding? So we can, I mean, whom would you like to see? Let's say let's start with the children.
Yeah.
They bleeding every fortnight, every 3-4 weeks.
Yeah.
It's been happening through the 3 months. I had 5 bleeds. So whom would you like to see?
Yeah, so yeah, bleeding in children is very common in healthy children as long as you know the child is healthy and there is no underlying blood disease and he complains of repeated nosebleeds. So the first advice to the parents to do 2 attempts of nose pinching at home, that they should put the child in the position leaning forward, head down, and pinch the soft part of the nose for about 3 to 5 minutes. Then the child should try to clear his nose. If the bleeding recurs, they can attempt again same maneuver for another 3 to 5 minutes. And if the bleeding still, the child still bleeds, so he may need to go to.
Let me rephrase my question. So if the bleeding stopped, then
yeah.
after 2-3 weeks again, 2-3 weeks again. So I'm facing, I mean, a concerned parents or carers.
Yeah.
So they would like their son or daughter to be seen by a specialist.
Yeah, I know this. We see a lot of patients like this. So the first attempt to most common cause this is idiopathics and maybe vestibulitis. So we typically give them a chance first to have a local antibiotic inside the nose in the septum cream to control any vestibulitis or inflammation inside the nasal mucosa, and also lubricate the nose. If these measures control the bleeding, so that's it. If it is still repeated bleeds, so he may need to be seen by a specialist for cauterization. So yeah, if the bleeding like this, the resistant bleeding, and it cannot be controlled at home with the measures that I explained, 2 attempts at home of nasal pinching, and the patient is still bleeding and needs to be transferred to the hospital for control. So this should be cauterized. If it always controlled at home, but it is annoying, repeated more than 2 per week, or once per week, and eventually repeated after using the cream, so it may need to be cauterized. The cautery, nasal cautery, is very simple and very effective in controlling the bleeding, as the patients are happy to, parents are happy to have the cautery. It is better than conservative treatment actually in controlling the bleeding.
Any particular investigations you would like primary care doctors to do or to run before they send the patients over to secondary care in children?
Well, actually, in children, as long as there is no history of bruises or any history of previous
no suggestive, any suggestive signs
of bleeding disorder,
okay.
And there is no family history of such bleeding disorders, there is no concerns actually, not to do any investigations.
What about adult groups? So
yeah, actually
recurrent controllable epistaxis on the same side.
Yeah, actually epistaxis is a disease of extremes of age in children and all the ages. In children, most commonly it is epistaxis. In all the ages, most probably due to secondary cause, either hypertension or anticoagulants and so on. So it is very rare to find it in middle age personnel. If it is recurrent in middle age, I'm not concerned, no much concern, as long as they are healthy. It can be like the children, can be used conservative measures first. If it's still recurrent and annoying, so we can do the cautery after examination. But there is something I didn't cover this in my lecture. I'm sorry, but in children with repeated horrible nosebleeds, this may be because of nasopharyngeal angiofibroma, which is a very dangerous nosebleeds. So in such patients, usually male child in the 10 to 13 years of age, comes with horrible nosebleeds, cannot be controlled at home several times, with also unilateral nose blockage. So this patient, this is actually cannot be controlled at home anyway, and should be discovered while he attempted to be treated in the emergency settings. In also middle age groups, there is a nasopharyngeal carcinoma, that also may be presented with a nasal bleeding, nosebleeds. If I see a patient, middle-aged patient, healthy, has no other issues, I do examination of the nose, I find a local cause, I still worried about any post-nasal cause of like post-nasal mass, like nasopharyngeal carcinoma. Okay, so yeah, in middle-aged patients, I should
Chinese or Asian.
yes,
Group,
like that. Yeah, in the primary case setting, I'm yes. If you find such patient, you should search for red alert symptoms and signs of head and neck.
Usually put a red flag in. Chinese from Chinese heritage, middle age with nosebleed or otitis media.
Yes, that's right. This is common in Chinese people because I think they eat a lot of fish, smoked, salted fish. It is a precursor for risk factor developing the nasopharyngeal carcinoma. In adults, in the older age group, I would say 50% of them are due to local cause, pinching the nose, dryness of the nose, like the pediatric group, and the other group due to anticoagulants and the hypertension and so. And most of them needs admission and indirect therapy with the nasal backing. Still most of them after doing nasal backing stay in the hospital for 1 or 2 days and go home. And small percentage of them may need to be admitted for surgical intervention.
Thanks for your insight, Dr. Ahmed Elazab, and thanks for your time.
Thank you very much.